Hello, my name is Sarah Marowski, and I'm an undergraduate student researcher at the University of Wisconsin School of Medicine and Public Health Department of Surgery. Today I will be presenting both gastric electrical stimulation and pyloric surgery offer long-term symptom improvement in patients with gastroparesis. Dr. Amber Shada received an honorarium for education from Medtronic, otherwise none of the other authors have anything to disclose. Gastroparesis is a disease characterized by delayed gastric emptying. Symptoms include nausea, vomiting, early satiety, and bloating. Gastroparesis has three different etiologies: diabetic, idiopathic, and post-surgical due to vagal nerve injury. Prevalence is 24 in 100,000, but more common in women, and gastroparesis is diagnosed by gastric scintigraphy of greater than 10% gastric content retention at 4 hours. Treatments for gastroparesis include dietary or medical, but for refractory gastroparesis, surgical treatment is available. Surgical options for refractory gastroparesis include gastric electrical stimulation or pyloric procedures. Pyloroplasty is often done laparoscopically, while pyloromyotomy is typically done endoscopically. Previous studies have demonstrated that these surgeries lead to significant improvement in gastric emptying and GCSI scores. One study of patients who underwent pyloromyotomy found that 78% of these patients had reduced or normalized gastric emptying post-operatively, while another study reported symptom improvement in 86% of patients who underwent laparoscopic pyloroplasty. A previous study of patients with gastric electrical stimulator saw that GCSI scores were reduced from 3.4 to 1.1 in diabetics and 3.9 to 1.1 in idiopathic gastroparesis 2 years after device implantation. The Gastroparesis Cardinal Symptom Index is a survey of 9 questions meant to evaluate gastroparesis symptoms. Each symptom is scored between 0 and 5, with lower numbers representing less severe symptoms. The average of these symptom scores are used for the composite GCSI score. An optimal GCSI score for a patient with gastroparesis is 2.4 or lower. The GCSI can be broken into 3 question types: nausea, vomiting, satiety, and bloating subscores. A limited amount is understood about how much each of these gastroparesis operations improves each symptom subscore. The study seeks to compare gastric electrical stimulation and pyloric surgery in their ability to improve subscores of the Gastroparesis Cardinal Symptom Index. We also sought to determine whether there were specific predictors of therapy failure. The records of patients who underwent gastric electrical stimulator, pyloroplasty, or pyloromyotomy between 2011 and 2019 were identified using REDCap. Patients were categorized into one of 3 groups based on the type of operation they underwent: stimulator only, which is GES; pyloric surgery only, which is PP; or combined gastric stimulator and pyloric surgery, which is GES-PP. Demographic data and preoperative 6-week and 1-year post-op symptom scores were also analyzed, and patients were grouped by operative success or failure based on post-operative GCSI score or reoperation. A GCSI score of 2.5 or greater at latest post-op visit was considered failure. Groups were compared with Pearson's chi-square test for categorical data and Kruskal-Wallis for comparison of continuous data. 97 patients were identified for this study. However, 15 were not included because they were a duplicate record, had previous gastroparesis operation, or no pre- and post-op GCSI score. This left 82 patients. Of these 82 patients, 18 had gastric stimulator only, 13 had a stimulator and pyloric surgery, and 51 had pyloric surgery only. The pyloric surgery only group was significantly older than the other group, with a mean age of 48, while the GES group had a mean age of 38, and the GES-PP group had a mean age of 37.7. The GES-PP group was less likely to be female, and the pyloric only group was more likely to have idiopathic or post-surgical gastroparesis compared to the other 2 groups, who were more likely to have diabetic gastroparesis. This graph depicts the GCSI score before and after surgery. The solid line indicates a score of 2.5, the established benchmark for a successful operation. The leftmost column displays the pre-op GCSI scores. The stimulator group seen in blue has a pre-op GCSI of 3.9, while the pyloric group in gray has a pre-op score of 3.6, and the combined stimulator pyloric group has a score of 3.5. These were not significantly different from each other. The stimulator-only group has a significant improvement in GCSI score at 6 weeks and 1 year mark, as denoted by the asterisks. The combined group has a clinically and statistically significant improved GCSI score at both 6 weeks and 1 year mark, and the pyloric only group has a statistically significant improvement at 6 weeks and a clinically significant improvement at 1 year. Next, we focus on symptom subscores. This graph focuses on nausea and vomiting subscores. All three groups had a significant decrease in vomiting and nausea symptoms at 6 weeks, and the GESPP and pyloric only groups maintained symptom improvement at 1 year. This graph is of the satiety subscores. There is a significant decrease again for the early satiety symptoms for all groups at 6 weeks, and a significant decrease from pre-op scores were continued at 1 year post-op for stimulator and stimulator plus pyloric groups. Finally, this last graph is of the bloating subscores. All three groups again had significant decrease in bloating symptoms at 6 weeks. Only the pyloric group maintained this decrease from their pre-op mean at 1 year. This slide compares those who had success with surgery to those deemed a failure of surgical therapy. A successful operation was defined as a total GCSI score of below 2.5 at their latest post-op visit and no need for additional surgery related to gastroparesis. These groups were similar in age, sex, etiology for gastroparesis, and BMI. Those who went on to fail surgical treatment for gastroparesis had a significantly higher preoperative GCSI score as well as a higher bloating subscore. However, nausea, vomiting, and satiety pre-op subscores were not significantly different between these groups. Those with diabetic gastroparesis had the highest rate of success with over 80%. They were followed by the post-surgical gastroparesis group who experienced success 71% of the time, and the idiopathic gastroparesis group had the lowest success rate at 65.7. There's no statistical significance between these groups. However, these rates are in line with published success rates of these surgical treatments. This table has details of patients who underwent a second operation for gastroparesis. Median time to second operation was 8 months. All etiologies, both stimulator and pyloric surgery groups, are represented. Interestingly, only 3 of these 10 patients had improvement in GCSI into the success range of less than 2.5 after their second operation. This suggests that the failure of one surgical therapy may predict lower success with any subsequent surgical therapy. There are some limitations to this study. This study was done at a single center, potentially limiting its generalizability. Also, adjusted analysis was not done due to the small sample sizes, so there may be some confounding. Gastric electrical stimulation and pyloric procedures are both effective as long-term treatments for gastroparesis symptoms. Combining gastric stimulation with pyloric surgery did not improve symptoms more than either surgery alone, and 71.9% of surgeries were successful, independent of gastroparesis etiology. Worse preoperative nausea, vomiting, bloating, and satiety symptoms were less likely to be improved by surgical intervention.